All right. Thanks, guys, for coming out. We have a good group today. So my name is Maureen. There's a little bit of technical difficulties, so I did have a nice PowerPoint with some pictures and some bullet points, but you don't get to see it because I can't connect. So I'll make it work. All you get to see is my face, unfortunately, and some of the movements that I will make. So please forgive me if I am a little discombobulated without. So the first part, I just want to say who I am. So a lot of you all know me from more of my professional life as a PT, but outside of being a physical therapist, I'm a mom. I have two little boys, a 2-year-old and a 5-year-old. And my husband, Luke, who's also in the medical realm, he's a hospitalist. We've been married about 14 years. And grew up in the Midwest. Never thought I would land in California ever in a million years. And then my husband had his residency out in Oakland. So that's what took us out here in California. And we love it. So now our home is in Petaluma area. Professionally, you guys know me a lot through PD Connect, which is one of the organizations that I work with. As a physical therapist, I am board certified in neurologic physical therapy. And then more specific to the Parkinson realm, I am LSVT certified, which we'll talk a little bit more during the program. But that's a specific protocol for exercise and movement to help slow progression of Parkinson's. I partner with PD Connect, which is a nonprofit that provides group exercise. And then I also have my own business, piggybacking off of that and being able to work one-on-one with clients, mostly inside of their home. Okay, so just quick overview of the presentation. Also, if I'm going too fast, raise your hand, tell me to slow down, tell me to chill. I need that feedback. I want to make sure you're getting good information, but I don't want to just cram a bunch of stuff in too. So if you need me to slow down or repeat something, please feel free, let me know. We're going to go over just quickly about Parkinson's disease, specifics of diagnosis. We're going to talk about a couple symptoms. We're going to go straight into then physical therapy treatments. We're going to talk about gait training, fascination, retropulsion. We'll talk about different walking aids. We'll talk about stretching, balance, and group exercise at the end. All right. Well, first, okay, I said I wouldn't involve that much exercise today. People did ask me, how much exercise are we going to do if you're the speaker? I'm going to involve a little bit. So if you're able to, I actually want to start warming up. We're going to do a little bit of the twist together. So if you're able to, stand. If not, you can do it from your seat as well. I'm going to play Chubby Checker here. All right, and then we just want to get loose. I need you to move around with me a little bit. Good. This is helping me get my jitters out too. Thank you for exercising with me. Good work. Good. We have one more song. I want you guys just entertain me here. This one, I want you to play either the air drums, the air saxophone, or an air guitar with me, okay? All right, you guys know what's coming up next. I need your voices with me, okay? I feel better. I hope you guys do too. All right, so we're going to start with quickly just going over specifics about Parkinson's disease. So we know that Parkinson's disease is mostly diagnosed through clinical symptoms, and it's not diagnosed with imaging, which makes it a little more difficult for practitioners to diagnose, and they tend to underdiagnose because of that, because they don't want to misdiagnose. So a lot of times it might be your physical therapist that first will see some of these symptoms. Maybe if you're coming in for some shoulder rehab, or you're coming in for some knee rehab, and your physical therapist starts to see a couple symptoms that they start to pick up on, some slowed movement, some tremors. Maybe you're only swinging your arm part of the way on one side. These are some of the first symptoms that we usually start to recognize. So for a diagnosis, you need bradykinesia, which is slowed movement. And that's the main symptom that you need for diagnosis, as well as one of these other symptoms. You need either rigidity, tremors, or postural instability. So 78% of people with Parkinson's disease have idiopathic Parkinson's disease, and that's more the kind of your classic symptoms that you would think of with Parkinson's. We have then secondary Parkinson's, which is Parkinsonisms, and that usually happens from trauma. It can happen from tumors, it could happen from toxins, or sometimes medications can induce Parkinson-like symptoms, or it could be metabolic. And then to further complicate Parkinson's, we then have these diagnoses called Parkinson plus syndromes. And those are PSP, progressive supranuclear palsy, MSA, which is multiple systems atrophy, Lewy body dementia, and then the fourth one is cortical basal ganglionic degeneration. And those four diseases are much more aggressive. So we don't get to do as much exercise typically. Medication typically is not as helpful if you're diagnosed with one of those, unfortunately. And then just the progression is ultimately a lot faster than idiopathic Parkinson's. So why can it look so different from one person to another when you walk in the door and you say you have Parkinson's? All these different symptoms, right? So we have a tremor-dominant Parkinson's, we have a rigidity-dominant Parkinson's, and then we have a mix of those two. And then with that, you also have all these other independent factors, like your comorbidities, like your function of your heart, if you have diabetes, what your exercise looked like before you were diagnosed with Parkinson's, what medications you're on. All of this then plays a role in maybe how Parkinson's is affecting you in your life. Okay, so moving on into physical therapy world. When you walk into a physical therapy clinic, what should they be looking at? We really want to make sure that when you see a physical therapist, a lot of times, if you are seeing the physical therapist for the first time with Parkinson's, you are already probably at a mid-stage of Parkinson's because we've missed the diagnosis early, or you've been functioning and trying to work still and just getting through life. Physical therapy has not been a priority, so you haven't been able to get to see the physical therapist until you're already at mid-stage, which is when you start to have more symptoms come on physically, and then maybe some cognitive decline as well. So what your physical therapist, what do you want them to look at? First, you want to set some goals with them. What is the hardest thing to do at home for you right now? Is it getting in and out of bed, in and out of a car? Is it walking from your bedroom to the bathroom at night? Getting that information to your physical therapist that you're working with is really important, because they can zone in on what they're practicing from a functional standpoint. A few other things you want to make sure that you get from your physical therapist are baselines. I've worked with a handful of you to get these baselines, but you want to really get an idea of where your balance is at today compared to 6 months from today and 6 months down the road from that. If you have a baseline of where you're at with an objective balance exam, then you're gonna know, oh, I've progressed this much, or this has gotten a lot worse or a lot harder. How does that relate to then my balance overall? So there's one balance assessment called the Mini Best Test, and the neurologic chapter of the Physical Therapy Association recommends that specific balance assessment for Parkinson's, because it involves looking at balance reactions. It involves looking at your gait, and it adds in some dual tasking with that gait. And then it looks at static and anticipatory balance as well. And then from a strength standpoint, it involves a heel raise or a calf raise and a sit to stand. So it gets a little bit of the functional strength. So it's only 14 different items, but it's a really good baseline to use to see where you're at today, so you have something to objectively compare when you get a reassessment. So speaking of physical therapists, so just like when you go see your doctor, when you're checking in with your doctor, you don't go to your general practitioner to treat your Parkinson's. You go to your specialist. You're going to see your neurologist that hopefully is a movement disorder specialist. That's the ideal world within the medical field. For physical therapy, it's the same thing. Please don't go to your general outpatient orthopedic physical therapist and expect them to be great at treating Parkinson's. They won't be. It very much is a niche within the physical therapy realm to work more with people that are battling neurological diseases. So you want to find someone ideally that has either their neurologic certification specialty, which is what I have, and it's NCS, would be at the back of their name for their credentials as a PT, or more common is you would find someone that has either their PWR certification or their LSVT certification, which are those specific exercise protocols to follow for a physical therapist to help guide someone to slow progression of Parkinson's. To find a therapist that is LSVT trained, you can go to their website, lsvt.org. See, look at the PowerPoint, it says it up there. Oh wait, it doesn't. And then the PWR one is PWR4life.org. And on both of those websites, you can actually search through zip code to see who's in the area that is trained with these two different certifications. Generally, where do these physical therapists work? If they're not in our general outpatient orthopedic clinics, which is mostly what we see when we're driving around, where are these people at? Well, there's me. But I work more in the private realm. So I partner mostly with PD Connects, who provide these group classes and to be a resource for you all. And then I do take one-on-one consults, but it's a fee for service for my business. And it's more as a consult than a program where you're gonna be seeing me every week. If you're looking to really get in and see someone routinely, which you should, about every 6 months be checking back in with a physical therapist to recheck baselines and function. Typically, a neurologic certified therapist or one with LSVT or PWR certifications are going to be working closely within a hospital. So up here, it's within the Providence realm through Kaiser, you're gonna find some of those neurologic certified therapists. And then down in Marin area, UCSF, associated with UCSF. So we're generally going to be working closely with the hospital because as a physical therapist, that's actually where I get to see more people with neurologic dysfunction, versus if I go to an outpatient orthopedic clinic, 90% of people that are walking in there is all orthopedic. So if you're looking for someone, it's a really good idea to check out those two websites to find someone that has one of those certifications. We know in this region, we have, like I said, Sutter, and we have, and his company, they have two different components. We wanna make sure when you're practicing these movements or your practice is going to be difficult because the fear is holding you back. So if you're really wanting to perform big, large amplitude movements, but you're really scared while you're doing it, it's not gonna work. So we wanna make sure if you're practicing, you're putting that effort in to improve certain movements, set yourself up that you're either able to hold on with one hand, or maybe you're using a walking pole or stick or your cane to hold on to for safety, so that you can really focus on the leg movement in a really big pattern. Yes, it takes away the component of what your arm is doing, but if it's taking away fear, it will overall improve the movement quality. Since I teach group exercise, this is really important because sometimes we have 30 or 35 people all exercising in the same room. And I can tell as a therapist that there's a lot of people that are scared of falling as we're making these movements. So as you're moving, you're not moving as big as I know that you can. So modify those, even in group classes, whether it's with me in PD Connect or it's in Rocksteady. If you need to be holding on to something for stability, or you need your care partner to be behind you and giving you that extra support for safety so that you can make bigger movements, it's worth that effort so that you get more out of the movement. Because we don't want to practice movements only giving 50% of effort. That's not going to create neuroplasticity. We really want to make sure we're getting that high intensity, so we want to bring down the fear level. Another component that physical therapists really want to touch upon when you see one is aerobic training. Generally with Parkinson's, over time, as the disease progresses, the aerobic training goes down. And there's a big clinical trial going on right now called SPARX, S-P-A-R-X, and it's in phase 3 of clinical trials currently. It's being run by Dr. Daniel Korkus out of Northwestern. He's the lead principal investigator. It's the first randomized controlled trial looking at the difference between moderate intensity exercise and high intensity exercise. So moderate intensity is where most of us typically live when we're doing aerobics. We're walking, but we're also able to maybe talk with our friend. I'm not really breathing that heavy, but I'm on the bike, my legs are still moving. So your heart rate is up a little bit, but if we really want high intensity, we need to be at a level where I'm working hard, I'm slightly out of breath, right? I don't want to be able to talk to my neighbor as I'm doing jumping jacks. And that's the high intensity that we really want to get at. There's great results already coming out of this clinical trial showing that the Parkinson's can be slowed more with that higher heart rate. So if we can get to that high intensity during aerobic exercise, that's the most ideal. I always tell people, start small. Maybe you can't get on a bike and ride at high intensity for 30 minutes today. That's okay. Start small. Can you do it for 5 minutes or 6 minutes? And just try to bump up by 1 minute at a time, trying to get intensity and endurance to get back in line, because that is going to overall help slow the progression of Parkinson's. All right, so much to talk about. We talked a little bit about evidence-based treatments. PWR is Parkinson Wellness Recovery, and you can look that up more online, pwrforlife.org, or LSVT, which stands for Lee Silverman Voice Treatment, because it originated as a speech therapy program, but then they included and adapted to make it also a physical therapy program. It's LSVT Big. So taking a look at that website might give you a better idea of these movements. When you are doing exercise, we want to make sure we are incorporating one of these protocols. They are researched specifically for Parkinson's disease. So if you're not taking advantage of something that we already know there's good evidence that it slows progression, we're missing out. So I know in my PD Connect class, I do a lot of our LSVT movement patterns, and we incorporate our PWR moves every session that I teach. So you're getting a little taste of that. And then I always recommend that you're taking those movements and use 5 or 6 of them at home, and then that becomes your home exercise program too. If you need a reboot or you need more education on where do I start, what are these movement patterns, find a therapist that is certified in LSVT or PWR and get an appointment so that you can really deep dive into these movement patterns, get some handouts, get some practice so you feel more comfortable doing them at home, because working with a therapist once a week is not going to cut it. We really want you to feel comfortable with this exercise program at home so that you can do it every day. There's the exercise recommendation sheet from the Parkinson Foundation. A lot of you guys have received this as a handout. I usually have it at a lot of my classes. It's free online, and it was created by the Parkinson Foundation to give an idea of what we need to do for slowing progression down. So it has 4 categories. We have aerobic training, which the goal is 3 times a week. We have strength resistance training, which is supposed to be twice a week. And then we have balance, agility, multitasking is all grouped into one, and that's supposed to be 3 times a week. And then stretching, they recommend at least 3 times a week. But we know that the more we stretch, the more you get out of it. So that needs to be closer, in my opinion, closer up to 6 times a week of doing 15, 20 minutes of some stretching. We'll talk about more specifics of all of those coming up. Okay, we're gonna switch gears. We're gonna talk about gait training for a second, and then we're gonna move again. So, gait training looks a lot different depending on what stage of Parkinson's you're in. So it's a little hard speaking to a crowd about gait training, but I'm gonna do my best. I'm gonna break it up into stages. So early stage of Parkinson's gait training. If you're in early stage, you usually have just one-sided involvement. You're typically not using any type of assistive device, and you typically don't have any cognitive decline at that point. During early stage gait training, we are working on large amplitude movement. We're working on a ton of dual task training. So that means that I want to work with you walking while you're talking on your phone. Or I want to work with you walking, carrying in groceries out of your trunk into your house. Because those are functional movements that we need to do that are dual tasks. So I need to be able to focus on both those tasks and safely get into the house and not drop my groceries. For mid-stage, we typically still are working on large amplitude movement. That really is in all of our gait training. But with mid-stage, we start to have a deficit in perception and proprioception. So it's your body's awareness of what your arm is doing or what your leg is doing is starting to go down. So most people have one side that's more affected by Parkinson's. So we'll just say if it's that left side, you start to have decreased awareness of what your left arm is doing, how much it's swinging, or how big your left leg is stepping or turning. In that mid stage, we also start to have some cognitive decline. So we're not able to pay attention to that left arm as much anymore. Dual task training can still be possible in mid stage of Parkinson's while gait training, but we just have to take into consideration fall risk and safety. But typically, if you're working one-on-one with the therapist, we still want to be pushing dual task training because it's something that we do day to day as humans all the time without thinking about it, 2 things at once. Late stage. So late stage of Parkinson's, a lot of people are like, we don't want to be working on gait anymore. We just need to be doing transfers, or we just need to be getting in and out of bed. That's not true. We really need to try to still maximize functional standing and stepping movements. Yes, maybe it's not 100 feet outside on uneven ground, and it's just going from your bed into your bathroom, but we still really need to work on that quality of gait. And then also coming up with strategies that you might be having to overcome fascination or freezing patterns at this point. In late stage, typically, there's a lot more cognitive decline, which means that we no longer are working on multitasking or dual tasking. We're working on one single task at a time. And we are starting to heavily involve your caregiver, care partner, your friend, your spouse. Because it's going to be now on their shoulders to really help make sure in late stage that we're trying to do single task as much as we can. Because if you're the one with Parkinson's in late stage Parkinson disease, you don't realize that you're getting distracted by all these things around you. You don't realize that you've lost your ability maybe to pre-plan because executive function has gone down or your visual spatial deficits have changed. So that's where it becomes really important for the caregiver to understand these deficits, to be able to give the right verbal cues to allow you to be successful. Okay, so I want to, if we can, I would like you to stand again with me. If you'd rather sit, you can do it in sitting. But I want to practice arm swing for a second. Can y'all still hear me? Yeah. Okay, so I talk about this a lot at class. We want to make sure that your arms are swinging symmetrically. So a great exercise to practice at home, you want a slight stagger in your feet, and then we're just going to practice with our arms that movement, reciprocal movement of driving both in front and behind your body. Okay, keep practicing. So what we see a lot of times is that the one side that is more involved from Parkinson's tends to stop moving behind your trunk. This is really important because that's what helps to shift your weight as you're walking. So pay attention right now, just as your arms are moving, are both your arms moving in front and behind your body? Good, go ahead and stop. Switch your feet so your other foot is out in front. And then this time I want you to swing your arms, but with your elbows bent. And really drive your elbows back. That requires a lot of core strength. As you're driving those arms, your heart rate already starts to come up with that reciprocal movement pattern. All right, thank you guys for getting up, moving again with me. Okay, I'm gonna switch to sometimes not using a mic because I need to use my hands. So when you're gait training with a physical therapist, all the time we need to make sure we're making large amplitude movements. A lot of times when I'm working with someone, if you need an assistive device, I prefer walking poles if it's safe for you. And that is really dependent on each person. But even people that are in late stage of Parkinson's disease can still use walking poles. Typically, maybe they use them together as a unit instead of reciprocal, but typically walking poles improve posture a lot more than a walker does. I kind of have a love-hate relationship with walkers, and I'll talk about that more later in the session. But walking poles are a great tool and highly recommended if you have Parkinson's disease because they force reciprocal motion with your arms. And almost always we have one side involvement with an arm. And so if you're using a pole, it's going to pick up on that deficit more, forcing more awareness of how your arm is or isn't moving. And then it force bigger movement from that arm that's involved to bring that pole forward. So I'm going to give a little bit of an example here with my poles. I want you to watch me here. This is what I would consider large amplitude walking. Okay, I know you think I look ridiculous, but that's how we need to be practicing because that's high intensity. You can hear in my voice, my heart rate is up just from doing that, right? I am putting in a lot of effort and power, not only through my feet, but through my arms. I'm getting that sound, that external sound, I'm getting that auditory cue back to my brain saying that that hand is landing down on that pole for better support. So the poles can give you a lot of that cueing without someone verbally having to say anything to you. A couple other things that I really like to include for gait training specifically. We need to be practicing starting and stopping movements on command. So practicing quick movements of stopping in place and then starting again, stopping in place, starting again. We need to practice changing directions while walking. I'm going to have you practice walking backwards, walking forwards, backwards again, forwards again, and I'm going to mix it up, make it random, that you never know what to expect so that I can actually challenge your reaction to see what your body does to improve your stability then when you're out in the real world and someone cuts in front of you and you have to stop quickly or take a step backwards to not run into them. It's great to practice with obstacle courses. So if you are with your physical therapist and they set up an obstacle course and you're like, not again, here we go. The obstacle course is great because it's forcing you to really pay attention to how big you're picking your leg up, or it's going to really show your perception or proprioception deficit when you keep kicking the cone that I'm asking you to go around every time you go around to your left or towards your right. So it will help to really pick up on those deficits and increase awareness. Obstacle course training has also been shown through evidence that it helps a lot with freezing of gait, which we'll touch on later. One other thing as a PT I want to make sure that we're doing is trying to force freezing. Freezing looks different for every single person, and their triggers are different. But if I can start to force that freeze while I'm working with someone, then we can work through it, and I can give you those strategies in the moment. A lot of times when I'm working with someone, they're not freezing, unfortunately, because we're doing all the right things, which is a good thing. But then it's hard for you to carry over that task then in the bathroom when you're trying to get from the hallway to the toilet and you freeze every time you go over the little threshold. So if I can really force freezing during PT, I can help to improve some of your strategies and work on different ones that might work for your body that are different than your friend. Okay, we're moving on from gait. No questions, Linda. I didn't talk about questions, actually. I will save room at the end for questions. Hold on to it. All right, we're moving on. Freezing. So how many people does freezing affect? Let's just raise your hands in the room. How many people have had freezing before? Which is where your feet basically stuck, or feel like they're stuck in the mud and you can't pick them up. Every day, yeah. So freezing affects 25% of people with mild Parkinson's and 80% of people with late-stage Parkinson's. And it's the leading cause of falls for Parkinson's. What causes freezing? So freezing is complicated. It is not just motor. So it's not just because the disease is progressing and my steps are worse, I can't get my foot up as much. That is a part of it, but a bigger part of it is actually the cognitive part of it that comes into play. So there was a good research article, a systematic review in 2023, just a couple years ago, that was looking at the relationship between cognition and those that are freezing and not freezing. And there is a correlation between cognitive deficits and freezing. So we know that with cognitive decline, which happens as the disease progresses, we know that your visual spatial deficits start to change, your attention starts to change, your executive function, and all of those are needed when we're walking, especially in busier environments. So understanding your triggers for freezing is really important. Everyone's triggers are different. So this is very independent for you. So it's really important for you to know what your triggers are for freezing. So when it happens, take a mental note of it, write it down, because these are things you need to be sharing with your physical therapist so that they can help you through strategies. So knowing your triggers, some triggers for people are crowds, distracting environments like going into a grocery store, turning in place or turning to sit on a chair can be a trigger for some people. Doorways, thresholds, curbs, all of these are different triggers, but they may not be your trigger. So knowing what for your body really triggers freezing is going to help us to be able to come up with strategies to decrease it. Dr. Jessica Bath spoke for PD Connect on our speaker series about a year ago, maybe less, but it was in 2024. And she spoke about the current research with freezing of gait, and she works at UCSF, has her PhD, and is a physical therapist. So she talks about a window of opportunity before you freeze. So if you know what the trigger is, say it's a curb, and you see that curb ahead of you, we have a window of opportunity to start to use these different external cues that can help you to avoid that freezing episode. That window might be very short, or it might be a little bit longer if it's something like a curb or a doorway and you see it coming up. If we see those things and we know that that's one of those triggers for you, we want to start to use strategies. So a couple strategies that can work for people. One is motor imagery. So stopping, thinking about yourself, walking up to the curb, stepping onto the curb fluidly, just thinking about you successfully doing that will automatically help you to perform that task. Counting your steps can be a great external cue. You want to go from the hallway to the bathroom and you always freeze on through the threshold or the doorway, then try to count your steps from the hallway into the bathroom. It's using a different part of your brain when you start to count. So it allows you to be successful to get through that tight space or that trigger. There are 4 S's to remember with freezing. The first one is in the episode, as you feel yourself starting to freeze. The first thing you want to do is stop. The second thing you need to do is stand tall. Third thing is shift weight. And then the last part is step big. Okay, so 4 S's, and I had this written for you guys, but stop, stand tall, shift weight, step big. And really the key so much of the time is that standing tall. Because if we can get your head over your trunk again, and that automatically shifts your weight, then you're going to be set up to be able to take a big step following that. We never want to try to push through a freeze. That's what causes falling. So if you are trying to just ram through it, like I can get through it this time, don't do it. It's not worth it, because from a neuroplasticity standpoint, you're training your brain that this is just how I get through freezing. But it's leading into falls down the road then. So we want to really practice as soon as you start to feel it, or you're in late stage of Parkinson's and your care partner notices that you're about to freeze, their response will be stop. Jim, stop. And you just try to stop in place. We change that posture. We try to widen our base of support. If your feet are really narrow and on top of each other, we need to get you shifting your weight, which means we need your feet away from each other. Take a deep breath, and then you try that next step out of it.
Are you going to take questions at the end?
I will. I'll take questions at the end. Yep. Other strategies for freezing. These are some of the tips and tricks I share with people when I'm working with them. One of the things that can really help is your vision, your gaze, and finding targets. So if you have that threshold or doorway where you always freeze, you need to get your eyes up and look past that doorway. If your eyes are glued on the threshold as you're walking, you're definitely going to freeze right before you hit the threshold, because you're thinking about it, you're looking right at it, you're scared about it. Your symptoms of Parkinson's will get worse when that fear increases. So we want to look past it. So that can work really well for furniture in your house. If there's that one chair that you always freeze around in the living room because it sticks out a little bit too much, or around the dining room, or it's a threshold or a doorway, use that strategy starting today. Try to look past it to get around it. It will really help to improve your steps to get through that and avoid that freeze. The other thing I really like to use is destination estimation. And this is something that is basically playing a little trick on your brain. So if you know you're going from your bed all the way to your favorite easy chair, and you always freeze right through the doorway when you're trying to go out through the living room, I want you to think about estimating in your brain, okay, how many steps is it going to take me to get from the bed over to my favorite chair? And I want you to challenge yourself to estimate less steps. So if you think, it's probably about 20, tell yourself, I'm going to do it in 18. And then you get up from the bed and you try 18 steps to that chair. Again, it's tricking your brain because you're no longer thinking and working on just automatic movement. You're thinking about your steps. You're taking big steps because you just told yourself you can make it in 18 steps instead of 20. So if you put that little strategy, it's called gamification, and it helps to improve mobility, especially in troubled spots in your house where you always freeze. So try that today when you get home. The other thing we want to practice is turning techniques. A lot of people freeze when they're about to turn. And then turning leads into a fall if your feet are too close together. So turning practice inside of your home can be really successful at decreasing freezing episodes. So practice, a lot of times people get stuck when they're in small, tight spaces, such as your closet or in the corner of your kitchen by a countertop. So in those environments where it's the hardest inside of your house, I want you to practice turning big in a full circle. I work a lot in class on 90-degree turns. We are practicing big movements up and over so that we can do a full 360, leading with one leg, then we switch and do the other direction. Practice that in repetition at home, in your closet. Because your movement looks better probably when you're in class with me and you have more space, if you have the space. Sometimes we're tight, but if you have the space, your movement's gonna look better. If you have this nice big environment and you can move, you have all the wiggle room you need, your movement's gonna look better. And I put you on a nice, tight, tiny little closet all the way in the back where your shirt is. Your movement's gonna look smaller because you're perceiving that you have less space. And because you're perceiving that, your brain is telling you, I need to move small. I only have a small space, so I can only move my feet small. And then you make 18 steps as you're trying to turn out of there. So practice in that exact environment, that big 90-degree turn to get out, 180 degrees to walk out of your closet. All right. We're almost done with freezing. We have just one more slide here. I'm going to talk about the other strategy that works a lot if you have trouble turning are U-turns. So if you do have that open space available to you, instead of making a tight turn, you take that available space and make it this big U-turn, which will help to avoid that freezing. So if you have the space, take it, make that bigger, wider movement. The other thing that can help are marching turns. Marching, because it picks our feet up bigger. Or stomping, yeah. Or sidestepping turns. Because sidestepping is a little bit easier sometimes if you're having trouble picking your knees up, but you still have that side movement, then you start to do this arc of movement to try to get out of those tight spaces. That works particularly well in your kitchen. And then one major thing with freezing is, we talked about posture. The more forward your head is over your base of support, the more likely you are to get frozen in place because you've narrowed your base of support as well as shifted it onto your toes. And we don't have good mobility all the way up on our toes. So we want to make sure that we are keeping our body weight over our base of support. And this is so, so important in the house. If you're trying to reach to that countertop in your cupboard, your favorite coffee cup is all the way up above the fridge for some reason in that cupboard, and you're reaching all the way out here, you're way more likely to get frozen there. So you want to rearrange your life within your closet, your bathroom, your kitchen, the spots where you're at the most. Rearrange your life to make the things you use the most very accessible at about chest level, and not in really tight spaces where you're going to have to do a lot of reaching, because you're more likely to freeze if you're having to reach outside of your base of support. Okay, let's practice some coordination. So I do an exercise a lot in class. We call it the hunter and the bunny. It's a fun coordination exercise. Everyone loves it. It's challenging, but try it with me. So we're going to have your bunny is going to be on one hand, and then you have your hunter on the other hand. I'm going to have to put down the mic. So you have your bunny hop across the screen as your hunter follows the bunny. Don't let the hunter hop, though. Okay, then you get to the end of your screen, switch. Now your other hand is your bunny, your hunter. Your hunter's hopping across the screen, Or your bunny's hopping, and the arms are going after it. Switch. Good, one more. Bunny's hopping, hunter's right on target. Good, that's just a good coordination exercise. We're gonna do one more exercise. I'm talking too much, I need to get moving a little bit more. Can we do a power up movement together? So from your chair this time, we're gonna practice the motion. Sitting on the edge of your chair, you want your legs out wide. And I know I didn't set these chairs up to have much space between your neighbors, so you get friendly with your neighbor here. You're gonna practice with your arms. I want you to reach down towards the floor, and then we're all gonna say power up as we reach up, okay? Ready? Power up. Power up. Power up. Good. Power up. Two more. Power up. Good. Power up. And rest. That motion works on weight shifting in a seated position, and it's working on posture as we're reaching all the way up with those arms. Okay, we're moving on to fascination. Gosh, it's 2 o'clock. How did that happen? Okay. Oh boy. I want to talk about fascination, retropulsion. So fascination is where essentially your feet are trying to catch up with where your body is going. So it looks like this. Sorry. It's really common with progression of Parkinson's. So just like freezing, the first thing that you need to do is stop. Stop the movement pattern from continuing to happen. So if you feel yourself starting to do this, stop, stand up tall to get your head and the weight of your trunk over your base of support again. You can use a strategy if you commonly do that, and you know you do that throughout your house. Use a strategy of trying to take only 3 or 4 steps at a time and then stopping your movement. Take 4 big steps again, stop, stand back up. You don't want to allow your body to continue to get into these bad habits, saying, oh, I just got to get there as quick as I can. That definitely leads into falling. So probably most common spot that I see this happening is when we're about to sit, right? Because I see the chair there. I know I want to get to that chair, and I'm going to try to get there as fast as I can because I want to sit. So what happens, you're walking that way, and you just throw yourself into the chair. I see that all the time, even in class. So if you are noticing that you're doing that, you have to stop your body from that mechanical movement. That weight shifting is really what's driving that. So keeping your head up as you walk and fully make that turn, then reaching back and sitting controlled is going to help to prevent that fall. Some other things that might help with fascination are tape. Using tape on the floor, a laser on a walker, or a laser on a cane can be a great visual cue for how far you need to be stepping, so that it encourages those large amplitude steps. And then some of you guys have one of these walkers, but they're called U-step walkers, and they can be really helpful in late stage Parkinson's disease because it's the reverse braking. So it stops you from getting too much momentum forward. It basically brakes for you. And then you, to release that, have to push it to walk again. So that's another great walking device for later in Parkinson's disease. Okay, talking about retropulsion. Retropulsion is that falling backwards or pushing backwards. And it's really common as Parkinson progresses. The reason retropulsion happens is because of postural instability, impaired sensory motor system, and rigidity. So all three of these things are setting yourself up, unfortunately, to want to push backwards. We all have a fear of falling forward. So sometimes because our fear is so big of falling forward, I don't want to weight shift far enough forward in order to fully stand up. So my body prevents me from shifting forward. Then I end up back on my heels. So I'm here. I don't want to go too far forward. I don't want to fall forward, right? That's what my brain, body is telling me. So what I do is I don't weight shift that far forward at all, which means that every time I'm trying to stand up, I'm just going right back down because I never got my weight of my trunk and my head far enough forward to be able to stand. So retraining that movement pattern is very easy at home. Find the chair that you constantly fall back in. Your favorite easy chair, or maybe it's a kitchen chair or the toilet. Practice from that very chair. Wide base of support, big weight shifting forward, and standing up with big posture. High repetition, high specificity, because it's from the surface that you have trouble with consistently. And then we have big effort level as you're retraining your body that it's okay to lean this far forward. I still have control here. In class, I use my hands a lot for that reaching motion to help retrain that weight shifting. But almost everyone as Parkinson progresses has trouble with that sit to stand, and it's something we do, 100 times a day. So retraining that and working on that at home from your favorite chair can be a really good home exercise program that you can do to then functionally improve something that can make a big difference for you when you're not fighting yourself trying to stand each time. And if you're the care partner who's helping in that instance, you want to, as much as you can, try to keep your hands off of the person with Parkinson's. Because the more that you're shifting them forward, the more they're gonna push back because they're scared. So we wanna make sure instead of putting your hand on someone to physically push and pull them up, you're giving them verbal cues to lean forward or nose over toes or big weight shift. And let them just practice rocking for a bit if you need to really get that technique and that they feel comfortable again shifting to stand. If you do it for them, it will not work. It will create more fear for them and more of a caregiver burden for you because you're gonna end up lifting way more weight than you actually need to. So if you have Parkinson's, that trial and error of practicing and retraining your body of how far forward you have to shift is really important to try to improve that sensory motor deficit that has occurred. So it's something that you want to practice every day at home if it's something you struggle with. Try to do it every day for 2 weeks and see if that can improve it so that you have a few months of positive movement again. It's like a reboot or a reset for that motion. Okay, I know I'm out of time. I had so much more to talk about, guys. Okay, I didn't even mention PD Connect. Lisa's gonna kill me. So I teach a group exercise class in Santa Rosa. Some of you guys wear your PD Connect shirt. I was gonna put mine on and say, now you recognize me, right? So we meet once a week. I'm at the Finley Community Center in the senior wing on Tuesdays at 11:30. You don't have to sign up ahead of time. You can just come, walk into the senior wing, they'll lead you to the right room, you take a seat. I'll Usually every class I ask if there's any new people, or if I don't recognize you, I'll have you come up and to get to know you a little bit. I'll have you sign a release of liability just to work with me since I'm a licensed physical therapist. And then we move and have fun for 60 minutes in large amplitude movement patterns that are very specific to both the LSVT and the PWR movement patterns. And then the other cool thing when I'm there is that I'm a resource for you. Okay, I can't spend 25 minutes with you, but if you have a question or you need help strategizing or problem solving quick, you have that opportunity once a week to come up and ask me for free, right? That's the other thing about PD Connect. It is the only program out there that I know that has physical therapists doing group classes in a donation style. So there is no fee, there's no membership. And Lisa Uwe is the founder of PD Connect. She is a firm believer that our community comes together to support programs like this. We are a nonprofit, and we solely work off of donations. And it's been going on for 10 years now in Marin County, and Sonoma County I've been working in for 3. So pretty amazing, a donation-based program, surviving, able to help so many people, regardless of how much you can bring to the table financially. So please don't let that hold you back. Come, participate. I want to meet you. I want to be a resource for you. The last part of my PowerPoint was just my contact information. My website is wiredphysicaltherapyandwellness.com, and that is a handful to remember. So I have some business cards in the back if you're looking for a one-on-one consult for me to come to your house and assess, problem solve, or talk about strategies with you. I can do that. I can meet virtually with you and set up an appointment that way. I am fee for service, so I can't go through insurance, but I would love to be that resource for you, even if it's just once a year and you need more guidance than what you're getting. And then please come to the class. If you come to that group exercise class, you have that weekly opportunity to come up and ask a question if you need it, as well as that social gathering to be able to socialize and find that support within our bigger Santa Rosa, Sonoma County community. Thank you all for letting me talk and hold your attention.